morning, everyone, and welcome to today's webinar hosted by PYA, OSHA's COVID-19 Emergency Temporary Standard, Implications and Next Steps for Healthcare Providers. PYA is happy to present today's webinar in conjunction with Realty Trust Group. You will have the opportunity to submit questions to today's presenters by typing a message into the question pane of the control panel. We'll collect these and address them during the Q&A session at the end of today's event if we have time. If time does not permit us to answer all questions, we will address them after the webinar by email. As well, all of our webinars are recorded and released with a copy of the slides after the event. With that, I would like to introduce Jeff Bushong, Consulting Principal at PYA, and Hank Carr, Senior Vice President at Realty Trust Group.
Good morning, everyone. This is Jeff Bushong. I am a principal at PYA, and it's my great pleasure this morning to introduce my colleague, Hank Carr, Senior Vice President at Realty Trust Group, or RTG. This morning, we are going to have the opportunity to share with you information related to OSHA's Healthcare Emergency Temporary Standards for COVID-19. Just a couple of points we wanted to make. As you hear us refer to ETS, those are the Emergency Temporary Standard that we are referring to. So rather than spell that out during the course of the event this morning, we will probably use ETS. As Laura mentioned, Hank is part of Realty Trust Group, or RTG. And as I mentioned, I am a partner at PYA. So let us begin this morning. Our overview this morning is going to cover a number of different areas, and it will be broken into two sections. I will be handling the first portion of our program this morning, where we look at the applicability of these ETS standards to the various healthcare organizations. We will talk about some immediate key next steps. We will have some overview information about vaccination status, OSHA's statement regarding vaccinations. We will talk about the importance of communication to not only employees, but also to patients and visitors. We will also spend part of our morning today talking about potential issues and solutions that may be encountered. Hank and his vast experience in real estate will talk about some very specific facility and real estate considerations. One thing we wanted to point out is that OSHA's done an excellent job of providing many tools for reference. We have included at the bottom of a number of our slides links to those OSHA references. So if you're thinking about, geez, I need to develop a plan, there are sample plans, there are documents, there are flow charts. Much of the information that we will cover today is obviously taken from OSHA's direct standards that were published in the Federal Register. But we will point out as we go through these slides, tremendous resources that OSHA has prepared. So you don't have to worry about starting from scratch, but rather you will have the ability to access these documents. First, we want to talk about who's impacted, the applicability of these standards to a variety of healthcare organizations. On the phone, as we looked at our participant list, we saw that there are individuals representing a vast array of healthcare organizations, including hospitals, which come in obviously many different settings, from general acute care to specialty hospitals, teaching hospitals, LTACs, a whole range of anyone that might be licensed or designated as a hospital. And as I mentioned just a moment ago, at the bottom of this slide, you will see a link to all of those various settings that are covered by these ETS standards. OSHA's done a really nice job of very clearly articulating what organizations are impacted by these emergency temporary standards. So I would draw your attention to the bottom of the slide. As Laura mentioned in her opening remarks, we will be providing the entire slide deck for your use and reference. In addition to our hospitals, ambulatory care facilities, which come in a vast variety, but just in simple summation, could or would include physician offices, all kinds of different specialty care clinics, as well as ambulatory surgery centers. In addition to these other ambulatory care facilities, you could think of dialysis centers, you could think of chronic pain management clinics. And really what I believe OSHA did is really to make this much more inclusive rather than exclusive as it relates to who's impacted by this. This applies not only to independent practices in most parts, but also to hospital and health system employed or contracted providers. Home health care is also an area. And if you think about why OSHA came up with these emergency temporary standards, it really is the protection of not only caregivers, but also patients and their families. So that's why hospice, home health care therapies, infusion therapies, physical therapy that may be included as part of a home health care service delivery. It's really about the protection of obviously employees, but really to minimize the exposure to patients and families. Sometimes if you're focused on either an ambulatory or a hospital setting, we forget about that our emergency responders are a big piece of the care delivery. That includes everything from ambulance to medical transports to air ambulance companies. But all of those pre-hospital providers are obviously part of our continuum and are obviously impacted by the ETS standards. At the other end of our continuum is obviously long-term care, whether they be nursing homes, skilled nursing facilities, substance abuse centers, rehab facilities, behavioral health, psychiatry. All those long-term care facilities and providers, for the most part, are also going to be included in these standards. We will talk throughout our conversation about what this means to the physical plant, but also programmatically. My lens really comes as an operations person. Hank obviously is going to bring a vast amount of experience when he talks about the facilities and physical plant implications of what these ETS standards mean. But again, we have listed below a list of those settings covered in the OSHA link at the bottom of not only slide 4, but also in slide 3. So let's talk about some immediate key next steps. You can see listed are half a dozen bullet points. Many of your organizations have addressed as part of the response your hazard assessment. But the development of a formal COVID-19 plan is obviously one of the things that's included in those standards. There are actually on the OSHA website examples of what that formal COVID plan looks like. And I would encourage you, if you're looking to see, is my particular plan as comprehensive as the standards indicate, benchmark it against what you've developed and also refer to the tools that are on that OSHA website. I think it's helpful if you say, well, geez, we don't offer a particular service or this area may or may not be included. Use that as a reference point. As it relates to establishing and maintaining an exposure log, that standard is very clearly delineated within the OSHA standards as well. And remember, going back to what I said earlier, and that is OSHA's main objective is really to protect workers in the healthcare environment from potential exposure to COVID. So maintaining and developing that exposure log is an important component of that. As we get to Hank's portion of the presentation this morning, he will address many of the physical environmental issues and some of the challenges of filtration and air handling and making sure we've got fresh air exchanges. But we'll also talk about physical barriers, how it relates to clinical and non-clinical areas. We will get into that in a little more detail. We also are suggesting that you go back and evaluate your current COVID policies and procedures. As this has been an evolving experience for many, we want to make sure that you have another tool. So we would encourage you to look at that OSHA website link that we discussed before to really look at sample policies and procedures. Obviously, each organization has its own unique challenges, and we'll need to adapt those to make sure they are appropriate for your organization. In the OSHA standards, there's quite a bit of discussion about training and ongoing training for employees. And I think it's like any other good management practice. It's training, it's retraining, it's confirming that the staff, managers, et cetera, really know and understand what are those standards, what do we need to make sure we're doing to best protect ourselves as well as our staff and our coworkers. We will continue to talk about the physical environment issues, but one of the things that we've obviously reviewed and read, and that is the installation of physical barriers. This morning I was at a family medicine residency teaching clinic where you can see how in that environment they have adapted barriers, obviously not only just in the check-in area, but checkout, nurses stations, et cetera. And the OSHA standards do define what areas need to have which kinds of barriers. And there are obviously different standards as it relates to physical distancing for the non-clinical direct patient care areas. Certainly cleaning and disinfection standards. OSHA references the CDC guidelines. We would encourage you to work with your environmental services and your housekeeping vendors as appropriate to make sure that those standards as they're defined and described by CDC, we would certainly refer you to the CDC website, which has tremendous details as it relates to what those standards are. As it relates to your building maintenance plans and making sure that there are appropriately functioning mechanical systems, in particular your HVAC standards. And certainly we reference the ASHRAE standards as it relates to those maximum fresh air changes. So if any of you have been traveling since some of the airline travel restrictions have been lifted, a number of the airlines on their own websites talk about the number of fresh air exchanges in their airlines. It's a similar approach to what they're saying by OSHA as it relates to buildings, which is maximum fresh air changes in your settings. As Hank will describe in some of his comments, some of this may be a challenge, particularly if you're an occupant in a building that you may not own, and or being in a facility where the original standards and HVAC systems were built for one particular portion of your building, but you may have had additions, renovations. But sometimes going back to the original source documents are important to see what was the system originally intended to be able to do. We talk about masks, we talk about respirators throughout, but there's also the air filtration systems within the facilities, the MERV rated filters, and those MERV 13 as being the benchmark. One of the challenges, as we know, whether it's PPE or other supply chain, COVID's really disrupted some of that. So the availability of those MERV 13 filters may or may not be available based on your suppliers and your supply chain. We'll address some of those questions that we anticipate you may have floating around in your mind. Also making sure that as it relates to the cleaning of your intake is coming on as part of your normal routine with a specific emphasis. Down at the bottom of this page number 6 on this slide, also some references for some of the publishing we've done at PYA that may give you some overview information as well. Not too many days go on where vaccinations and vaccination status aren't the lead news story, both on national and local news. But just as a reminder, there are 3 vaccines that are currently approved for emergency use: the Pfizer, the Moderna, and the Johnson & Johnson. And many of you, I'm sure, are aware that the guidelines for vaccination was lowered to age 12 and older back a couple of months ago. And certainly OSHA has a long-standing position statement that they believe of the importance of vaccination. We are not going to get on the political discussion and debate, but this just gives you an idea of how OSHA looks at vaccinations as it relates to preventing illness, particularly as it relates to job exposure. In one of my opening remarks, we talked about communication. And I think communication is also part of what we do as good management. And that's making sure that we've developed and implemented a plan for each workplace. And when I say each workplace, our hospital colleagues may say, well, that kind of makes sense, because our imaging department is different than our laboratory department. That's different than perhaps our central billing office, et cetera. But making sure that we have developed and then implemented those plans, and that there is not just a one-time communication, but an ongoing communication, because I think we learn as we implement these plans what we need to modify to not only make it better, but make it as appropriate as possible. As managers and as employers, we obviously have a duty to make sure that we're performing hazard assessments, making sure that we're doing risk assessments. And that certainly is through observation, but also through working with our staff and our leadership group to make sure that these assessments continue on a routine basis. We did this presentation a couple of weeks ago to another audience where the whole concept of face mask and respirators, we're not going to get into that in great detail, but we will cut to the chase and say, for the most part, employees must wear a face mask with the exception of limited circumstances. One of the other things that we see as we've worked in hospitals as well as in ambulatory and other facilities is access by non-patients. So many of our organizations that we helped out obviously are not letting family members or visitors accompany patients. So we need to make sure that we can have safe handoffs as patients come to our organizations and our facilities, and that we really limit the amount of traffic that's non-appropriate into our clinical spaces. We continue to look at the 6 feet indoor distancing as an important consideration, but we want to make sure that we're also using common sense in that approach. I mentioned in an earlier comment about those standard practices for cleaning and disinfection. The CDC guidelines are still a great source and a great reference tool that we make sure that it's protecting not only as OSHA has intended the employees and the workers, but also our clinicians who may not be employed but certainly be working in these areas. Employees, the standards are pretty clear. They have to be screened prior to each workday and each shift. We also need to make sure that, as we talked about in one of the opening slides, that we are making sure that we're developing a log if we have anyone suspected of having COVID-19 or those COVID-19 symptoms. We want to make sure that we have, as part of our plans that we talked about, understanding how transmission of COVID occurs, and mask wearing, hand washing, gowning, frequent glove changes, et cetera, are all part of that. As employers and as leaders of organizations, that duty to make sure that we notify through contact tracing anyone that may have potentially been exposed within that 24-hour window. We also want to make sure that as we encourage vaccinations as one of the things that certainly helps dramatically reduce the spread, that we provide that reasonable time off. And as I mentioned in an earlier comment, that we have that log to document any instances of COVID-19, regardless of whether we think that exposure occurred in the work site or not, unless there is an exclusion. So at this point, I'm going to hand this over to my colleague, Hank Carr, to continue the presentation.
Thank you, Jeff. Here we go. Well, folks, thanks a lot. It's a real pleasure to be here and to participate in this. As Jeff introduced to me, he explained that I'm an operations guy, or excuse me, I'm a property manager, and Jeff really manages this conversation from an operations perspective. And so we really do come at it from two different perspectives. I really enjoy and drilling down in the physical environment. So I'll do my best to unpack some things. I will try to get in some detail here, but I will tell you just right up front, the official guidelines have been posted on almost every slide that you've seen here. There have been links and references to the OSHA websites, and so we want to encourage you to check these standards as we talk about them and make sure you agree with us. But when we start talking about this, you know, all this hit us pretty hard, and I think everybody really wants to know, well, does this apply to me? And what does it mean to me? What's the impact for my business? And so I thought I'd start there. And one of the easiest areas to start to talk about is, you know, when you talk about exemptions or exceptions to this ETS, one of them is if I'm in a non-owned or a third-party lease site, you may be entitled to a partial exemption. And I use the term may. There's some kind of qualifications here, but I'll unpack this a little bit. And so one example that we've heard used is you have a clinic, a nurse's clinic inside of an industrial site. And under that scenario, clearly the industrial site is not going to be subject to the ETS. But the clinic that provider operates out of is going to be subjected to some of the restrictions that Jeff outlined earlier. If you're in a retail setting, and I think today that is very common, especially in the urgent care world and some of these other settings, that you're leasing space from other folks. But in those particular situations, you know, you may have a unique site that's, you know, just yours, and you may be able to control all the air conditioning and all the physical plant inside your space. So again, depending on how your lease is written, you may be subject to the ETS, or you may get a partial exemption. Clearly, you're not going to be subjected to the common area guidelines that the ETS begins to weave in. And then the best example that I come up with is you have a clinic, you know, a primary care clinic or a specialty care clinic that's in a business occupancy type property. You're the only tenant in the building, and you're sitting there on the first, second, third floor, and they've laid all these regulations on top of you that says you've got to, you know, maximize your airflow and track your filtration for your system, and all these other regulations. And so the answer, again, it gets back to that example of the nurse in an industrial building. If you don't control the rooftop units, it's a little hard for you to dictate to your landlord how those units are filtered. But if you, and is an example of where you might have to be careful. If you're in a building that has a water source heat pump system and you've got independent units inside your space that control just your space, then you would probably need to at least attempt to meet the filtration standards and the air exchange standards. All these things really begin to make this a little bit of a complicated process, and I'll talk a little bit more about how you might address that in a few minutes. So, you know, third-party lease sites is one way. Another area that everybody really wants to talk about is there are certain non-clinical or certain healthcare settings where you can get an exemption. And I'll be the first to tell you, and some people that are a lot brighter than me have read some of these guidelines, and it's not easy to figure out where you fit in the grand scheme of those directions. But down here under, there's a website that's referenced down here, and it's a flow chart, and it's a really great tool for you to work through whether your clinic meets the standards. But you have to be careful and you have to look carefully at the definition, because when I think of the two examples that really are prevalent here are where you're in a non-hospital based clinic, so it's housed in a medical office building, providing ambulatory care. And so the guidelines would suggest that if it's in that environment and all non-employees are screened, and all people coming into that clinic with suspected COVID symptoms are refused entry, and you can document that, then you may be entitled to an exemption. But if you are in a hospital setting where ambulatory care is delivered, they add another wrinkle to it, and they say that all employees must be fully vaccinated. All non-employees, so vendors, non-employees or vendors, people that are visiting the site, are screened, and anybody that presents with a COVID-19 symptom is refused entry. In that scenario, if you meet those standards, you could be exempt from the ETS. So we'll talk a little bit more about that whole concept of fully vaccinated in a minute. There's a couple of other exceptions. One of them that comes to mind is pharmacy, and I think I can't remember whether Jeff touched on it, but if you're a pharmacist and you're delivering, you're preparing your meds and handing them across the counter, you don't have to comply with ETS. But if you're delivering other healthcare services from that location as a pharmacist, you will have to comply. So there's some fairly granular processes you need to go through. And again, this flow chart at the bottom is extremely helpful. And I'm going to provide some more information here in a minute that I think will matter, because it's where the process and the inspection comes together. You know, when we talk about exceptions, we were all exempted up to July 21st. And so we threw this in there just to really impress upon everybody that these guidelines are now official. And I'll be the first to tell you that I anticipated there would be some delays in this rollout. Some very big and powerful organizations submitted requests, ASHE and others submitted requests to have these regulations, pushed back, delayed. And to my knowledge, there have been no delays. There have been no new carve-outs, and no new exceptions. The only thing that we can kind of rest on a little bit here is these are classified as temporary temporary restrictions. They list this ETS as temporary. Now, the people I talk to are not optimistic that all of it will be relieved at some point, but portions of it will be when the pandemic begins to relax. I'll change and talk about where it impacts your checkbook or your pocketbook a little bit. And obviously, these are really pretty obvious. To some of them are, but I manage a bunch of budgets, and so administrative staff to manage all these screenings and these logs and all this reporting. And I'm going to talk a little bit more about why that is going to matter in a second, but it is very important that you get these logs up to date and report anything. Jeff's already talked about environmental services and janitorial enhancements. And so I will tell you that from an operations perspective, the industry in a lot of ways was cleaning for appearance for a long time. And when COVID hit, and obviously the CDC guidelines rolled out and evolved, and now they're fairly set, it really begins to matter. So you have got to have clear janitorial specifications, and you've got to be consistent, and they're going to cost more money in our experience. The next item is maintenance, planning, and engineering systems evaluations. So I've got some folks on my team that are just really smart. A guy named Gary Rosado, and I said, Gary, explain to me what this means. And he helped me write some of these notes, and he explained it to me this way. Ambulatory buildings have been operated in a run to fail method for years. There is just years and years of deferred maintenance built up. So as this ETS rolls in and we start to see and feel these new regulations on air changes and filtration and cleaning, not only in your space but your equipment, cleaning the equipment, it is going to make a big difference. So that's we have operated these buildings and said, well, when it breaks, we'll just replace it. And what they're really telling us is that's just not acceptable anymore. We want you to keep up with your engineering systems. When you think about supplies and materials, obviously, well, here's some kind of quick statistics that we get is you will have your filters will cost twice as much, and they'll last 60% as long. Now, it's not a huge item in the list, but it's really going to matter over time to get to a MERV 13 rating. And then you get to the unknown. We don't have enough experience with this ETS to know how these new standards of MERV 13 filters are really going to affect us. So capital equipment failure and or upgrades to meet minimum requirements is going to be a learning curve, certainly for me and our team and our clients. I suspect for everybody, because they've asked us now to upgrade all this equipment to its manufacturer's specifications, and we've been running what I'll call MERV 8 filters for a long time. And so now we're going to go back, it's old equipment, and we're going to ask it to run at its original quality. And by the way, we probably haven't maintained it as well as we could have. And so now we're going to ask it to run in its original specifications, and the equipment is not going to handle it. And so that's a learning curve piece, but you're going to have to monitor the equipment, and you will see failures, capital equipment failures in the process. I think it's inevitable. So I picked this next slide just to kind of transition to my next topic, which we all sit here and want to know what the solutions are, what are the issues and the solutions. I've always been told, don't bring me problems, bring me solutions. And so I wanted to take a minute and really kind of hit maybe the short list of issues and talk about some solutions. But honestly, this whole thing has been rolled out to our industry with what, 30 days, 3 weeks notice. Now we're 3 weeks into it, and literally we feel like we're pushing an immovable object. We didn't get a lot of notice, and so here we sit trying to figure this out. So we'll talk a little bit about the issues that I think are relevant, and I'm sure there are many more, but these are the ones that we're faced with every day. And the first one is, as we think through these exceptions, I talked about them a minute ago. What are the things that would help me opt out of the ETS? And so one of those requirements is you have to be able to identify that your team is vaccinated. And so that's already a challenge across many of our organizations. If your employees do not or will not disclose that status, it makes it very difficult to begin to meet the exception standards that OSHA has provided. Now, I believe that a lot of these standards really are put in place here to help motivate us all to move towards a vaccinated employment base, and they have enticed us. They've given us some incentive to do that. We talked about those third-party spaces. The landlord says, "Hey, it's your problem, not mine. It's your lease. You figure it out. I really don't have to comply." It's going to be a challenge. Buildings that lack test and balance benchmarks. We talked about those fresh air changes, Jeff did, and so you go, well, how do I get my hands on that? And the answer is going to be pretty tough, because that was usually done when the building was built. If it was a hospital-based clinic, those records probably exist, but if it wasn't, they probably don't. There are other ways to solve that, and talk about that in a minute. Physical barriers not possible or available. I went into a sign, essentially a sign shop, who was building physical barriers a couple of weeks ago, and I'd never seen so much plexiglass lined up on the tables, and a little bit hard to find right now. And so there's some real challenges in meeting the physical barrier guidelines. Unknown building maintenance plans and the lack of regulatory direction. So up here, a couple of bullets up says, well, I don't have any test and balance benchmarks, and you come down here and you go, I need to figure out what I'm supposed to be doing in this. And the first thing you have to do is kind of back up and dig through your plans, and you probably aren't going to have them. So now you're going to go out and look for regulatory direction. And what you really have to do in that case is begin to look for a subject matter expert. There are some organizations out there that can help with that, and we'll talk a little bit more about those in just a second. MERV 13 filters not available. I mean, I don't want to say very few, but a lot of organizations were not utilizing these standards of filters up until 3 weeks ago, and then they tried to buy them, and they're not available, and it'll be months before they are. So what's really happening now is people are, well, can I get MERV 11s? And that's really a great solution, because it starts to step you into a more restrictive airflow for your system that's probably old. And so you're going to have some challenges with just buying and finding the equipment you need. And then when you do, your equipment is just not going to operate. And we talked about that a minute ago. It's just not going to function correctly. Your maintenance staff's going to get the call and go, hey, it's hot in here, and it's stuffy. I've got a high moisture content. All kinds of things start to show up when we start playing around with our filtration systems. And in the healthcare environment, it matters. So this is these are some real issues that I think we're faced with. When you kind of look into the future, and you go, well, how do you solve this? And the advice I'm giving to everybody, my staff, my team, my clients, and anybody I talk to, is document everything you do. We all know that in healthcare, but in this particular case, we're really pioneering new ground with this ETS. We've never been in this world where OSHA's they've always been a player in our inspection world, but never this level. And we don't have a lot of experience in how they're going to, I'll use the term survey or inspect our properties. And we better have a really clear documentation of what we've tried to do. Because if you can't prove it, it didn't happen. The fines for non-compliance are fairly steep. $13,653 per violation, and that's for a serious violation. And you can get down here. Well, you can Google OSHA fines, and it'll give you some more definition for these violations. But it's also discussed down here in this link to the OSHA government enforcement site. Same amount per day for failure to abate a problem after July 21st. And then it's 10 times that, if my math is right, for willful repeat violations. And so these are serious numbers. This is not a small amount of money in the grand scheme of things. And so the thing everybody probably wants to know, well, what does an inspection look like? What happens? How does this go? And so that website is the best resource. It's a fair amount of information, and when OSHA or any government entity releases this data, it can be wordy. In this particular case, this one is not. It doesn't have a lot of fluff in it. It gets to the point pretty quick. In over 50 plus pages, it tells you with clarity how this process works. And I'll just try to summarize it for you at a fairly high level. But if they visit your site, what they're going to do then is sit down for an opening conference, and they're going to ask to see your safety director or your representative, and they're going to sit down with the person who's responsible for your COVID-19 plan, and they're going to try to evaluate whether you have an exception. So we're here to visit, this site at such and such a street, and it's this clinic, and they're going to ask you a series of questions that are going to unpack whether that site meets the criteria for an exception. And then they're going to ask if it doesn't meet the criteria for an exception, they're going to ask for your hazard assessment plan. So early on, Jeff talked about the hazard assessment plan, and then further on in his presentation, he talked about how important it was to have that plan for each location. So as I was reading these directives, these enforcement directives, the one thing that really stuck out to me is they want to see a plan for each location. I think Jeff's reinforced that, and I'm suggesting the same, because if you write a plan for your company, just say you're an MOB group or a hospital system, and you write a plan and you say this covers all my locations. You have 20 locations. As I read it, I think there's some exposure for 19 locations. Maybe that fits one of them, but they're looking, the way I read it, for a plan, and it can be a very similar plan for each location, but it needs to be thought out and really well planned for each location. It matters. The hazard assessment plan really matters to them, because that's where they get started. And then they start looking at your logs. Jeff talked about the logs. They look at your communication plan. They look at your policies for masks and everything. And so they'll start drilling down at that point, and then they'll stand up and start a walk around. And this is just how they outline it. So as I kind of come in to the end of my part of this conversation, as I reflect back on what has happened over the last, 6 weeks, give or take 8 weeks, there's nothing really new in here. We thought and knew that air changes were going to be a big deal when we rolled back into the workplace after that initial you know, hey, let's lock everything down for March and April. And we knew air changes were going to be a big deal. We didn't think about the filtration issues. We didn't think about some of these things, but you know, the truth is there's not a lot of new things in here. But up until this point, up until, you know, the 21st of July, they were all recommendations and suggestions and guidelines, and now they're regulations. So they really matter. And this this inspection process is one that we have to learn about, because I'm not aware of anybody that's been inspected yet. I have heard of some systems being notified of a pending inspection, but I've not experienced one yet. And so that's a great place for me to pause for a second. I'm going to hand it back to Jeff, and we'll carry forward from here.
Thank you, Hank. Laura, I think we do have time for a couple of questions, and I'm sure that, you know, the complexity surrounding standards and clicking, you know, going to the OSHA website, it'll probably raise additional questions, but perhaps we could try to address a question or two before we wrap up our time with the participants today.
Sure, thank you, both Jeff and Hank. We do have some questions, and let me get right to them. The first question that we were asked, and we were asked several times this one, is there a definitive process for inspection?
Thanks. I'll try to field that. As I read the enforcement directive, what it suggests is that in the case of an employee death or a notice of violation from somebody, you can expect a visit and an inspection. So I think those are the two triggers today that would, I can't use the term guarantee, but predict, give you pretty good confidence that you're going to get a visit from an OSHA inspector. A lot of people would tell you that OSHA, you know, they cover just, you know, all of industry. And so you just think about oil and gas industry and their responsibility is just to inspect those worlds. It's going to be a challenge. The one thing that I don't have this, again, I'm leaning back on one of my subject matter experts in our team, and he is learning that OSHA has leaned in on CMS and Joint Commission for some assistance in this inspection process. And so those are, at least from my perspective, put some weight behind it. But I think it's an employee death and a reported violation of the ETS will probably get you a visit for sure.
Okay, thank you. We do have another question, and this one is, where do I find air exchange standards?
Yeah, I talked a little bit about that, and so this gets quite granular, and I'm not really qualified to answer it in great detail, but what we'll try to do is answer this back out in an email to the person that submitted this. But at the end of the day, OSHA really starts to look back at ASHRAE standards, and that is really where you have to start looking for information if you don't have it on your facility. So if you don't know what the air change standards are for your site, and you don't have the historical information from the original drawings, and you don't have the ability to go through and do a full test and balance, which is a pretty complicated and time-consuming process, you really have to start, again, get a subject matter expert. Let us know, and we can direct you to the right group, but you're going to have to go start leaning in on some industry standards, and ASHRAE is the gold standard for that. Other ones include the Facility Guidance Institute and the American Institute of Architects.
Thank you. We have one more. Will these regulations filter into a non-healthcare setting like administrative or industry?
Jeff, do you have any thoughts on this one?
Well, I don't think we really know at this time. There's not been anything that we've read or has been published as definitive. I would say to continue to monitor the OSHA and CDC websites for additional information. As we become aware of information, we will certainly share that on our respective websites as another reference tool, both through PYA as well as RTG. Laura, there was another question about where do we find the examples of the COVID-19 action plans? At the bottom of the slides, if you click on that link that takes you, there's actually a subfolder that actually provides sample COVID-19 action plans. As Hank and I have both referenced throughout the discussion today, we really want to make sure that we're going directly to the source. Lots of room for interpretation, but at least it gives you an opportunity to look at your plans that you may have already developed or look for things that perhaps you forgot to include in those plans.
Excellent, thank you. Just had one submitted. How long do you expect the ETS to be in effect?
Jeff, I don't know how to answer that at this point.
I would say it's like anything else that tends to be governmental regulations, but as far as we know, it's going to be around for the foreseeable future. You know, it's like anything that's relatively new or we don't have a lot of history. You know, we'd like to say, gee, the eradication of the COVID-19, you know, and then this will all go away. But we've been led to believe that many of these standards will become permanent. And I thought Hank made a really important comment earlier when he talked about cleaning for appearance versus kind of, whether you call it terminal cleaning or, you know, cleaning and the maintenance of air exchanges as well as contact. You know, I think the bar has been raised. So that's why I think that these standards are probably going to get converted to something permanent from their current status of emergency temporary standards. Hank, any other thoughts about that particular question?
No, I wish I had a crystal ball to figure this out. I think when I think about that question of how long is it going to be in effect, I kind of go back to some of the organizations, massive organizations that put pressure on OSHA to try to push this off, delay it, you know, water it down, just, you know, hey, take some of the sting out of this. And they were totally unsuccessful as far as I can tell. And that tells me that this set of guidelines they're serious about it. It wasn't done to be, you know, it wasn't done without a lot of thought. And it's hard for me to see how it gets softened or eased or released anytime soon. I think, Jeff, you said it best. This is the way of the future. We got to figure out how to work in it. And they're all good things, is the truth. They're just not things we've necessarily been doing consistently.
Hank, I would agree. And I think just as a final comment, the American Hospital Association was early on, as Hank suggested, where they proposed longer comment periods, more involvement by the hospitals to really be able to give OSHA feedback. To my knowledge, none of those recommendations were adopted. So stay tuned. Certainly the professional societies, as well as Hank suggested, certainly turn to your subject matter experts and your trusted advisors, because we believe that this will be an ongoing and evolutionary approach to this particular subject. So
Jeff,
I
I'd
think
like to
that's
just make one last kind of close the loop and go back. One of the notes I talked about, and I encourage everyone to look carefully at the definitions in here for hospital-based and hospital-based ambulatory and non-hospital-based ambulatory. It can have a different meaning for different organizations. It's very well defined at the bottom of that flow chart that we referenced in page 10, I believe. And I would encourage everybody to get that out, because that's really where many of you on this call will begin to go, okay, I either fit into this box or I fit into that box, and it'll give you a lot of clarity, I think.
great suggestion, Hank. Laura, we'll turn it back to you.
Great, thank you. And thanks to both of our presenters, Jeff Bushong and Hank Carr. If you have any other questions, their presentation and contact information will be emailed to you along with a recording of today's webinar. Also, if PYA can provide assistance with audit, tax, compliance, valuation, or physician services, please call or email us. You may also visit our website at pyapc.com for more details about our specific areas of expertise, or to subscribe to receive PYA insights. On behalf of PYA and Realty Trust Group, thank you for joining us, and have a great rest of your day.